Before we intubate a patient with TBI, we want to do a rapid neuro assessment focusing on three things: GCS, lateralizing signs, and the pupil exam. The pupils are easy. We're looking at size, asymmetry, and reactivity. For the GCS, we want to describe what we're seeing in each of those three realms as opposed to just giving a number. The hardest part of assessing the GCS is the motor component and differentiating withdrawal from localizing. In order to properly assess this, we want both a central and a peripheral stimulus. For that central stimulus, we're going to do a trap squeeze. What we expect to see if the patient is localizing to pain is that we squeeze the left trap and the right arm comes up above the clavicle and crosses the midline. If the patient is simply withdrawing to pain, you might see some shrugging of the traps or flexion at the elbows. For the peripheral component, we're going to apply a peripheral painful stimulus in each extremity and see if the patient withdraws that limb from that painful stimulus. This tells us that the peripheral nerves and the spinal nerves are intact. Lateralizing signs or signs of herniation are wrapped up in both our GCS and our pupil exam. If the patient has unequal pupils, if they're moving one side of the body and not the other, you should be worried about herniation. And that's it. If you check those three things, you are communicating a ton about the patient's neurostatus prior to intubation to your neurosurgery colleagues, which can help to dictate their management.